Welcome to the WCCBT Global Forum, a forum of the World Confederation of Cognitive and Behavioral Therapies, where we invite and amplify the voices of leading figures who have made an impact in the field of cognitive and/or behavioral therapies. I'm Dr. Lata McGinn. I'm president of the World Confederation of Cognitive and Behavioral Therapies. The mission of the WCCBT is to promote and advocate for global mental health and to develop and disseminate evidence-based practice through the formation, collaboration, and partnerships with individuals, organizations, and governments. I'm very delighted here to have Dr. David Clark here. Dr. Clark is a British psychologist and is a leading figure in the research and treatment of anxiety disorders. He is Emeritus Professor of Experimental Psychology at Oxford University, Emeritus Fellow of Magdalen College, Emeritus NIHR Senior Investigator, and is National Clinical Advisor at the UK's Department of Health. Dr. Clark has achieved numerous accolades throughout his career. He has received Distinguished Scientist Lifetime Achievement Awards from various psychological associations, notably the British, Canadian, Dutch, and American Psychological Associations, as well as from CBT associations across the world, such as the Academy of Cognitive and Behavioral Therapies. In addition, he's also been recognized by governments and organizations external to psychology and CBT. He was appointed as a Commander of the Order of the British Empire and was elected as a Fellow of the British Academy, the Academy of Medical Science, and the Academy of Social Sciences. So what has he done to get all these accolades? He's renowned for his work on the understanding and treatment of anxiety disorders. He has developed seminal cognitive models and therapies, especially for panic disorder, social anxiety, health anxiety, and PTSD. He is also the architect of the Improving Access to Psychological Therapies, or the IAPT program, which has now been renamed as the NHS Talking Therapies program. That is a program within the National Health Services of the United Kingdom that provides evidence-based psychological therapies for those struggling with anxiety, depression, and related mental health conditions all across the United Kingdom. The therapies are based on research and recommended by the National Institute for Health and Care Excellence, or NICE, and are delivered with fidelity. Progress is tracked to ensure that the therapy is effective and to improve service delivery, and practitioners receive regular supervision to ensure high-quality care. Dr. Clark's work on disseminating effective psychological treatments within the United Kingdom and across international healthcare systems is the reason we are sitting down to speak with him today. David, welcome to the WCCBT Global Forum. I'm delighted to be speaking with you today.
Thank you, Lata. It's a pleasure to be with you.
So I thought we could begin by just talking about the development and implementation of what you've achieved. So to set the stage for our discussion, could you briefly describe the Talking Therapies program and the key psychotherapeutic approaches that it's built upon, and for what populations, conditions, and ages are served through it?
Yes, so it's a program for treating people who are suffering from anxiety disorders or depression, and it covers all of adulthood from age 18 until death. It's a sort of triple public promise. People who come into the service for treatment are promised that they will receive a evidence-based, in this case recommended by NICE, that you mentioned, psychological therapy, delivered by people who are properly trained to deliver that treatment, and that their clinical outcomes will be recorded and publicly reported so we can learn from the success of the program and further improve its effectiveness. It started quite small in 2008, but since then it has treated nearly 9 million patients, and it's currently treating 670,000 every year. And we're able to collect outcome data, looking at how much you've improved in your anxiety, your depression, and also the extent to which they interfere with your life, from 98% of that 670,000 people. And that is true across the age range. So even if we look at those patients that we see who are aged over 90, we're
Mm.
still getting outcome data from 96% of the
Oh,
age
wow.
90 plus people. Um, so that's really the key structure of the program.
Um,
How does it do when you've got the outcome data? Well, when we set it up, we thought from the literature we should be able to get about 50% of people to fully recover from their anxiety and depression, so
mm,
come out of the clinical range for both conditions,
right.
and about two-thirds to show really worthwhile improvement, what we call reliable
Mm.
improvement. Um, and that is actually the outcomes we've been achieving for the last 9 years. Although when we started, we were a bit below that and we had to learn to get to there.
Wow, that's pretty incredible. Now, what was the initial inspiration behind the Talking Therapies program? And then as it began, how did your vision sort of evolve during its development?
Well, I think my personal inspiration was hopelessness. So I spent my early career, when my hair was a different color, developing, hopefully slightly improved psychological treatments for different anxiety disorders. And you mentioned, the three conditions that we worked on: panic, social anxiety,
Yeah.
PTSD, and also health anxiety. Um, and we were quite successful in that,
Yeah.
rigorous clinical trials. We showed we were doing a bit better than existing treatments. But then I sort of looked around and thought, well, are people getting these treatments? And in general, the answer was no, only very small numbers of people. So I thought, this is all a bit pointless, isn't it? Maybe I should have done something else with my life. And then I thought, but no, maybe we just have to work harder as psychologists to try and get these things implemented. I had the naive view that if you are successful in developing a new treatment and it had
Right.
good evidence for it in randomized control trials, then healthcare systems would just look at those findings and say, great, let's implement it.
Right. Let's go for it.
Yeah, that was the naivety of youth. And I realized it maybe it happens for drugs because, of course, you have a lot of money put behind them to get them into the healthcare system. But for psychological therapies, it generally doesn't happen. And so, we've got to do something about that ourselves. So that's what got me involved in the IAP program, hopelessness. But then there was a moment of hope for me. I bumped into, by accident, in a queue for a cup of tea at an academic meeting, uh, a world-renowned economist, Richard Layard, and I was talking about the frustration of people not getting the therapies and explaining that there's good evidence for them. And he looked at me and said, "Well, but what arguments have you used? Presumably you've used the economic argument, haven't you?" I said, "Oh, what's that?" And he looked at me as though I was the most stupid person he'd come across and said, "Well, obviously, if you get people better from their anxiety and depression, it will be very good for the economy. People will get back to work. There'll be less healthcare costs, and it's the Treasury that always runs a country. Haven't you been running that argument?" So we
Wow.
got together as a team and we ran that joint clinical and economic argument, and that's really what got the Improving Access to Psychological Therapies program going.
That's interesting. I did not know that, and it was an accidental meeting. That's so interesting. So how did you gain the support of policymakers, clinicians, and the public for such an ambitious initiative? I mean, that just seems so remarkable.
Yeah, well, the things you need to do to gain people's support differ depending on what the group is.
Yeah.
Um, for politicians, I discovered early on, with the help of Richard Layard, that, as one of your ex-presidents said, it's the economy, stupid. You have to really mount the economic argument. And if politicians think that making psychological treatments more widely available will have economic benefits, they're likely to go for it. So our arguments to government were very much to do with the economic benefits to psychological treatments. Um, if you're looking at patient groups, then of course what they can care about is that they get effective treatments and that they're respected in the way in which their treatments are delivered. And so we worked very hard with all the charities in England that represent users of mental health services. We said to them what we'd like to do, that we'd like to create this big public service, giving you a course of um, evidence-based treatment, and
Right.
asked, is that what you want? And they all said, yes, we really want it. And so we formed a partnership with them. And we wrote a document called the Depression Report, and we got a philanthropist to pay for it to be issued in um, the national newspaper one
Mhm.
weekend. It's a bit
I
like
see.
getting an insert in the New York Times, so
Wow.
a sort
That's
of free
wow.
insert there.
Yeah.
And that came out on the Sunday. But the mental health charities had said they wanted to produce their own pamphlet
Hmm.
using their own words, but to argue for the same thing.
Okay.
And it was called We Need to Talk. It was a great pamphlet. And we agreed they would release theirs on the Thursday after our pamphlet went out on the Sunday. And
Mhm.
the conscious effort between us and the representatives, all
Wow.
the patient groups, was we'll control the media for a week and we'll get attention that
Mhm.
way. And that was really important. So I think the big initial partnership was between the sort of clinical academics who really knew about the evidence and the power of the psychological therapist, the treasury
Mhm.
in terms of the government, and the patient groups.
Right.
Um, you might be surprised to hear that we didn't spend so much time trying to get complete agreement among the professional psychological
I
associations about
imagine
how
that.
to do it, because we
Yeah.
sort of realized, certainly me, who's been in them for many years, that
Sure.
it could take decades before they agreed on all the details. So we
Yes.
thought it's much better to get the
Yes.
funding and then people are likely to come along with it. And so that's how it worked out.
Wow, that's really smart. So it really took a lot of creative marketing and research and just the funding, which is absolutely remarkable. Now, you must have run into many challenges, but what were the biggest challenges in scaling it across the UK, and how on earth did you over address them?
Yeah, well, I think the first challenge was really being able to demonstrate to the government that what we were doing was effective. So we got a commitment from Tony Blair, actually, so the Labour government, in his sort of election manifesto that they would do this initiative. But once they got elected, they said this is a big deal. Uh,
Mm,
you've got good evidence for you, but you haven't shown that you can implement it effectively.
yeah.
So we'll give you a bit of money to do some pilots and let's see if they work out the way you expect.
Okay.
So we had a couple of pilots. We managed them very tightly and very closely and provided lots of supervision. And we had lots of great CBT therapists involved in it. And they did get the sort of results we anticipated. So the government said, okay, fine, let's do the program, but let's roll it out in a staged way. And so
Mhm.
we cover the whole of the nation in 3 steps over 3 years. That was wise. So the first um, issue, I suppose, was who gets funding first? Where do we scale
Mm,
it up first?
I see.
And obviously, there were political arguments to say you should go to the most deprived areas with the highest
Mhm.
rates of mental health problems. The only trouble is that those areas are often deprived also of skilled psychological practitioners.
That's true.
And so we thought that's not necessarily a good way to start because we'll need a
Mm,
partnership with some existing people.
sure.
So instead, we argued that we'd make it very competitive to get the initial money because we could only fund a small number of services initially.
Hmm.
And um, you would you would get money, to train a whole series of clinicians to join your service, but you need to have some experienced people to supervise them to start off with.
Okay.
So that was one of the criteria. Who could you put forward to help lead your new service? You also needed them to commit to collecting outcome data, and
Mm-hmm.
you needed them to work through a really good care pathway that was evidence-based. So
Mm-hmm.
we essentially interviewed a lot of local areas uh, against those criteria,
Right.
issued funding to the best, uh, most promising starts. That worked out well because they did well. Um, the ones who didn't get initial funding and were disappointed, they got a lot of feedback. And so when they came back the next year, they were much better equipped and were ready to do it. And so they tended to do it well as well. So that phased rollout seemed to be very important,
Okay.
really focusing not so much on which were the most deprived areas, but
Mm-hmm.
which were the areas that are best equipped to get going. Because
Got
we thought if we didn't demonstrate we were doing well from the start, we'd be closed down.
got it. So, right from the time that you meet Richard Leitner on The Economist, and then you do your clinical trials, then you have this pilot period, and then you did the 3 year. How many years is that altogether? Would you say?
So, in terms of getting in principle support for the program, it was in 2005.
Mm,
The pilots ran in 2005 and 2006.
okay.
The government then said, okay, we're going ahead with the national program.
Hmm.
Got a year to
Oh yeah.
develop all the training programs you're going to need for it and to develop the clinical model um, and um, to start appointing your
Hmm.
first phase of people. So there's a year of preparatory work. And
Hmm.
then the rollout was announced on World Mental Health Day in
Mm.
October 2008.
So now, what were the key considerations that you used in training and developing this workforce that was capable of really delivering this high quality therapy at this level of scale?
Yeah. So in England, we'd had lots of training initiatives in the past, which had all been pretty ineffective.
Mm,
Um, they'd been initiatives where people got a chance to go along to
mhm.
once a week, a training course with nice workshops and things.
Right.
Um, but then when they went back to their existing job, they found that they didn't see many of the patients who had the problems they were being trained to treat. And so they
So,
didn't really develop their skills, and they certainly
mm,
didn't end up, treating a lot of people with new skills. So we decided we're not going to do that.
mhm,
And so if you became a trainee in the IAP program, as it was called then,
mhm,
you had to give up your existing job and you got a new job, full-time
mhm,
job, um, for the first year as a trainee. And if, for example, you were a CBT therapist trainee, you'd have 2 days a week in a university um, with clinical workshops and things and supervision, and 3 days a week in the service seeing patients who have exactly the same problems that you've been trained to treat. And I think it was this tight synergy between
right.
the training and seeing patients with exactly the problems that you're being trained to treat, which was very important. The other important strand was to agree national training curricula. So we didn't, for example, just say, if CBT is one of the most common treatments in the program. It's not the only one, but it's one of the most common ones.
Mhm.
And we didn't say, well, you can go on a generic CBT training course. We
Yeah.
said, no, NICE recommends certain types of CBT for particular conditions. You need to go on a course which will train you in those particular forms of CBT for these conditions. And we will only pass you as having qualified if you demonstrate with videotapes of live therapy sessions that you have all the relevant competencies. And we developed a competency framework.
Mhm.
We had a national curriculum that all of the trainers, all of the universities followed, and we still do that. So I think that's been really crucial to get training which delivers the evidence-based versions of treatment. We,
Got it.
we also actually, for depression, support a range of other interventions: interpersonal psychotherapy, some brief psychodynamic psychotherapy, couples therapy. We organize their training exactly the same way.
Okay. Okay. Now I know that there are two aspects of it, the low intensity CBT and then the high intensity
Yes,
CBT. So I imagine the training is different for the
yes.
workforce on that.
Yeah.
So it's just less intensive. What would you say the low intensity therapists are able to treat?
Yeah. So the program, delivers whatever treatment's NICE the go
Mhm.
um, recommends, and so NICE recommends for depression and most of the anxiety disorders um, the low intensity interventions such as guided self-help
Mhm.
um, and behavioral activation groups, that sort of thing, for um, the mild to moderate cases.
Mhm.
At least as an initial intervention. Um, but if you don't respond to that, then you're stepped up to a course of more conventional, once a week CBT.
Yeah.
Um, for the more severe cases, NICE recommends going straight to the, um, the high intensity treatment. And for
Mhm.
two conditions, PTSD and social anxiety disorder, NICE says do not do low intensity intervention, go straight to high intensity intervention. So that's the way we essentially try and model it.
Right. Now I know you referred
So
to
it's a sort of more cost-effective way of delivering treatment
sure.
effectively.
That makes a lot of sense. Now, I know you referred to the research a few times. So I know a key aspect of the Talking Therapies program has been its focus on measuring outcomes
Yeah,
so that we can have these real world results. So, what metrics or outcomes have been the most critical for you in evaluating the success of the Talking Therapies program?
great. So I'm really pleased you're raising this because I see this as a sort of stardust that makes the whole system work, the outcome
Okay.
monitoring.
Okay.
So firstly, in terms of what we measure, um, we measure for everyone, how severe their depression is and how severe their anxiety is. But we also measure what I think matters more to patients, which is to what extent those symptoms interfere with their life in a lot of different domains, whether it's at work, at home, with their family, in leisure. And we use a work and social adjustment scale for that. So we measure all three of those things. Um, the how do we do it? Well, we're pretty unique worldwide, I think, in having such a large program which gets outcome data on everyone. I
Yes,
mean, we have a higher outcome data completeness rate than most randomized controlled trials.
absolutely.
So there are several keys to that. The first is that we give the simple measure of anxiety and depression each time someone is seen. We
Mhm.
don't waste therapy time on it. They fill it in before the therapy session. Um, But because we give it each time someone's seen, if someone drops out of therapy early, either because actually they just responded very well and they don't want to be bothered to
Yeah,
come back, or
right.
actually they're annoyed and don't want to
Yeah,
come back,
right.
we still get a clinical outcome point. So that's really important, the
Mhm.
session by session data. We also make the sort of admin of it pretty minimal. So mostly patients nowadays get an SMS message on their phone,
Mhm.
um, which reminds them of their appointment. They
Right.
click a link in that, and they can then fill in their questionnaires, and they appear on the computer of their therapist, and they and the therapist can look at the graphs and see how they're progressing. We train our therapists to use the outcome measures to guide therapy. So we're not just looking at the average score. Say
Right.
you're treating someone with PTSD. The
Mm.
PCL5 would be our measure of the
Okay.
PTSD symptoms. And your patient has improved
Okay.
since last time.
Mhm.
Then that's not enough. You want to look at the individual items. And in some cases, you'll find that what's happened is that the measures of intrusive memories have gone down. They're having less intrusive memories,
Mhm.
the measure of avoidance of triggers has gone up. That's not a good outcome.
No, that's
We're
not.
not making therapeutic progress there. And you know what you have to focus on in the next
Mhm.
session. But for someone else, you might find both of them have come down, and then you're staying on track and carrying the weight you do. So we teach people to use them to inform each session of therapy. Um, the other thing that we do, as well as reducing sort of admin burden, is we have a particular way of reporting the outcomes of the services, which is really critical.
Mhm.
So we obviously don't report publicly the outcomes of individual patients, but we have around 200 services, and you can log on anywhere in the world, and you can see the average outcomes for every one of those services. It's in the
Mm.
public domain.
Wow.
And um, w- how do we sort of record, for example, recovery rates? Well, say you treated 1,000 people and you got outcome data on 500,
Mhm.
and then of those 500, you found that 250 recovered. A lot of people might say, oh, well, then you've got a 50% recovery rate, is
Right.
half of the people you got data from. But we
Sure.
say, no, that's not what we're going to report. We're going to report that you've got a 25% recovery rate because you're only able to demonstrate recovery in 250 of the 1,000 people that you treated
Right.
because you've got missing data from 500.
Sure.
This
Sure.
is what we call a smart metric. When we introduced it right at the start of the program, a lot of people said this is unfair because
Mm.
some people who don't get data from will have improved. They're absolutely right. But we found it was a brilliant behavior change strategy because it removed any incentive from the services not to collect outcome data. And within the first year, all of our services got to more than 90% complete outcome data.
That's
So
that.
this was really, really important as a behavior change strategy.
So it sounds like you focus on both the training of it, like how to use the measures, not just as some bureaucratic thing that you have to do, but you really are looking at it to inform your treatment. But then you also use behavioral principles to shape their behavior to increase the amount of completion of all the measures, just because it would benefit their own outcomes for those patients, which is really wonderful.
That's right. And then, of course, once you've got the data, you try and create a learning community of the different services. So you bring people together regularly and look at what the data is telling us and how we can improve. And so some of our early studies showed that um, services which were all delivering the same treatments
Mhm.
varied quite a lot in the outcomes they got. And that turned out to be related to some organizational features. And so we could feed that back. So, for example, some services were very good at sort of specifying what they thought the key psychological problem was they were treating, or what we
Mhm.
call the problem descriptor. Is it PTSD? Is it OCD? Is it depression? Whatever.
Right.
Those services got much better outcomes than those services which actually were a bit vague on what the problem was. They
Mhm.
said, we don't like diagnosis, we don't like
Right.
classifying people, and they
Okay.
didn't. And they got much less good outcomes. But when we fed that back to the system, then everyone started to identify problem descriptors. We found those services that promptly step people up from low intensity to high intensity get better outcomes. Um, we also found that the average dose of therapy matters, and that those services that gave a higher average dose got better outcomes. But it's not a massive, the optimal average was about 10, but obviously some people are
Mhm.
getting 20 or 30 sessions.
Sure.
And crucially, we found that how long you wait before starting treatment matters.
Really?
We
Huh.
found that those services that on average would, after you've been assessed and it's clear you could, benefit from treatment, those services which on average get you going on your treatment within 6 weeks get considerably better outcomes than those people in whom the average wait is longer, even though the treatments are the same. It's like there's a window of opportunity, I think, that when you come in for psychological therapy, I think everyone knows you're going to be discussing emotionally difficult topics. And this is not always something that people are ready for. But when they tend to, refer, they tend to be up for doing that work, but you won't necessarily have that window forever.
Never. Right.
So,
Where
so
their
this finding,
motivation to change is
yeah,
high. Yeah.
you need to capitalize on it. And this finding changed government policy. The government now asks all of our services to see people within 6 weeks to start treatment because of that finding. But the other thing that we found is, whenever you collect a lot of data, you find lots of inequalities. You find, some people do better than others. And, one of the classic ones, and incredibly important, is to do with ethnic background.
Sure.
So we found back in 2015 that we were getting much better outcomes for the white population
Mhm.
than we were for the black population or the Asian population in the national data.
Mhm.
And, that is completely unacceptable. But when we looked at the individual service data, we found that wasn't always true. We found there were
Mm,
some services that were doing really well with
I
those
see.
ethnic minorities. So we looked, well, what are they doing? What is it that
Yeah,
they're doing that's different?
sure.
And we wrote that up in a positive practice guide and distributed that to all the services. And then a few years later, all the groups have improved in their outcomes, but the difference between the white and the black population had completely disappeared, and the difference between those two groups and the Asian population was much reduced. So
Gotcha.
this is where I think, it's just absolute magic having the data because you can spot these things. A lot of clinicians were not so keen on the outcome monitoring. Patients really loved it, but a lot of the clinicians were a bit fearful of it. They felt, oh, well, if we collect data on everyone,
Yeah.
maybe we won't be doing as well as we would like. And, that was a worry to them. And of course, often when you first collect it, you're not doing quite as well as you would like. But if you've got the data, you know what the problem is and you can focus on it, and you can always solve it if you know what it is.
Right. No, I think that's really intriguing. So the magic of data, I mean, that you were able to help the clinician see the benefits of it too, which
Yeah.
is just half the battle. So what was it that these therapists were doing that made the therapies more accessible or effective for the Asian and the Black populations that you noticed?
Yeah. So I think, there's quite a long literature, isn't there, suggesting that, maybe the therapy approach needs to be different. You need a, culturally adapted form of therapy. Actually, we didn't find that was the case in this instance. What we found it was very much to do with access. We found that there were some uh, groups in the community who felt less welcome in the service initially,
I
or
see.
they might tend not to turn up for their initial appointment, and the the service had a rather strict policy. If you don't turn up twice, then,
I see.
that's it. We're not offering you
Right?
treatment.
Yeah.
Whereas what we found there, the some groups that was more likely to happen to initially. So we had really quite assertive outreach to them, and were much more flexible about engaging them in the first place.
Hmm.
We did find that having some members of the team who are from a similar background was a big help. People could recognize that in coming
Hmm.
into the service. We also found that, reaching out to um, groups in the community who are particularly well connected to some subgroups, including church groups and voluntary groups, was a big help.
Hmm.
And we've also found sometimes that people who've gone through treatment before, who become sort of peer supporters and explain to people when they come in for treatment what it's involved and how it helped them,
Okay.
also help engagement. So we found a lot of the issue was more to do with engagement rather than the treatment that you
Mhm.
deliver.
Yeah, that's an important lesson.
It
Um,
could have it could have gone either way, but that's what we.
yeah, absolutely. And that's why the data was so important. Um, so now I understand that you've worked with other countries to implement evidence-based mental health programs. Could you describe the countries that you've assisted and the key adaptations that you've had to make to suit their cultural, economic, and healthcare contexts?
Sure. Well, I mean, obviously, every country is a bit different, and
Mhm.
so um, probably no country would want to exactly
Yeah.
copy what we do. You need to adapt it to your local culture. I mean, the two countries that started first on this similar issue were Norway, and
Mhm.
I've been working with them since 2011, I guess, and they now have their own version of the IAP program, pretty close copy, um, in 90 of their sort of local municipalities, and it covers 60% of the population. Um, it's pretty similar with one difference. So in the English system, we have different clinicians who deliver the low intensity treatments and the high intensity treatments. In Norway, it's the same clinician who delivers both.
Okay.
And, looking to the future, that's not a bad system, actually, because it
Mhm.
means that you don't get sort of gaps between, your low intensity intervention, your high intensity intervention.
Sure.
Um, they, the other country that I guess started very early was the Ontario, which has what they call their structured psychotherapy program, which has a lot of similar uh, procedures. And
Mhm.
Martin Anthony was the clinical advisor for that program, and of course, was very prominent in ABCT. Let me just have a glass of water.
Sure.
More recently, Spain and Italy have both, and Finland have been developing their own versions.
Mhm.
The Finns have been working at a great pace. In the last 3 years, they've trained 16,000 clinicians,
Wow.
which is amazing.
That is
Um,
pretty
and the
amazing.
Australians have had a range of different initiatives over this period of time, and they're just about to launch a new one. The fabulous thing, I think, from different countries being involved is that they all do things slightly differently, and they also do their research slightly differently. And so, as a community, we learn much more from each other. And in many ways, the community is much greater than the sum of its parts.
Yeah.
And I think a wonderful example of that is a research study that's been done in Norway recently. The nice thing about the Norwegians is that they've done a really elegant study um, looking at the benefits of the Talking Therapies program compared to standard treatment. So they did
Mhm.
a randomized controlled trial when they rolled it out in a new area,
Mhm.
um, where you either got treatment as usual in primary care,
Mhm.
including access to psychologists and psychiatrists,
I see.
or you went into the Talking Therapies program. They call it prompt mental health care.
I see.
They, they found that over the period of the trial, which was 2 years, that those people who went into the Talking Therapies program, the recovery rate was twice as high. So they doubled the recovery rate.
Wow.
So clinically, very valuable. But the wonderful thing about the Norwegian study is they could use data linkage to follow people up for the next 5 years in terms of their personal income and also their healthcare utilization, for other healthcare things. And what they found is that those people who are treated in the Talking Therapies program um, used less other healthcare services, so there was savings in the healthcare system, but they also had a higher income. Now, this is a really dramatic point because, in general, most economists say that if people's income is
Right.
increasing, your economy is growing. It's a direct measure of economic
Yeah.
growth. And they found that from year two after treatment, continuously, in year three, four, and five, and staying as big, the people who had the talking therapies treatment had a higher personal income.
Wow.
Now, how big is that difference? Well, it's about a bit over $7,000, that difference. Um, Now, if you take a program like ours, where we treat 670,000 people a year, and you multiply that by 7,000, you see that the Talking Therapies program is growing the economy by $4.7 billion a year.
That's
This is
remarkable.
absolutely extraordinary, isn't it?
Extraordinary.
And we presented this data to our own government, um, and they released quite a lot of extra money to further expand the Talking Therapies program here in England. And uh, the effect is so big that the Treasury says, well, if you close down the Talking Therapies program, we would have to reassess our projections for the growth of the economy.
Wow. Now that is
So this is like your
extraordinary.
Federal Reserve saying we have to redo our calculations.
I couldn't even imagine. Wow. That's extraordinary, truly. Um,
So this is really, some of the magic you can get by bringing different countries together and them all doing
yeah.
different types of research. In England, we've done a bit more research on the healthcare benefits. So, for
Mm,
example, we have some nice studies following people up for several years after the Talking Therapies program.
yeah.
Recent publication showed that for those people that we are successful in treating their depression,
Yeah.
they have less adverse cardiovascular events in the next 3 years. That's significantly less heart attacks and strokes. We also find if you follow them up for 8 years,
Hmm.
we're reducing the rate of onsets of dementia. So,
Wow.
really showing a very strong relationship between psychological health and physical health. And
Right.
these, of course, really together provide convincing evidence in practice for the arguments we put up in theory to get the
Yes.
program funded, which was that
Uh,
it's going to save you money overall.
yes, for sure. Absolutely. I mean, so it sounds like your data is sort of informing the work in other countries, and in reverse, their data is helping to also
Yes.
benefit your country. So, what advice, and I think this is what I would love to end with, what advice would you give governments or organizations that are seeking to collaborate with, experts like yourself to develop mental health initiatives in their country?
Well, I think the first thing is to say that, if you deliver evidence-based psychological therapies, and obviously CBT is one of the leading ones of that,
Sure.
uh, in an effective way, um, it is likely to have very positive effects, not only on the people who are suffering from it, because many will recover and their families will benefit enormously from it, but to have much broader valuable effects on society in terms of employment and economic growth. So that's the first bit of the pitch, if you like. Uh,
Mhm.
but I would also say, and I do say to most governments, but you know, you want to be able to see that your money is well invested.
Mhm.
So when you start to fund rollout of psychological therapies, do insist that the new services collect outcome data
Mhm.
and report it.
Okay.
And don't get too worried if it doesn't look absolutely perfect at the beginning, because you've created a learning mechanism. And uh,
Mhm.
psychological therapists are really inquisitive. If you give them the tools, they will solve the problem.
Yeah.
So if you give them the data, they will deep down into it and they'll work out how we can fine tune it and improve it. But
Yeah.
if you don't support them in collecting the data, you don't give them the systems to do that, then you're depriving them of some of their most valuable tools.
Um, Well, thank you, David. Is there any question that I haven't asked you that you'd love to sort of share with our
Well,
people
yeah,
watching?
just to say, obviously, countries vary a lot in how they organize healthcare
Mm.
systems.
Yeah,
Um, in England, we have a national health uh,
sure.
program. Obviously, Norway has something a bit similar, slightly different. Um, but in some, there isn't so much of that type of provision.
Yeah.
And the question is, well, how do you get going if you want to scale up
Mhm.
psychological therapies still?
Yeah.
And I think a wonderful example of that is Italy. So in Italy, most of the psychological therapy will be provided through private practitioners. So how do they try and get going with a scaling up evidence-based program? Well, the group in Milan based in actually in the Sigmund Freud University, but it's
Okay.
a university that trains people in CBT,
Oh,
has
wow.
been training people in CBT um, to go into private practice for a long time. And they've recently got together and they've created this amazing network of all of their private practitioners where they collect all the same data that we do in the
Mm,
IAP program. They
I
pool it
see.
together and they learn from it. And they're really improving the quality of what they're offering in private practice, but they're also collecting a database which they are intentionally
Mhm.
presenting to the Italian government, saying, "Look, it can be achieved. Now, please start supporting psychological
Mhm.
interventions more." So a
Interesting.
really
That's,
clever
that's,
system. And you can
yeah,
think in quite a lot of countries where
yeah,
it's much more private practice,
I
we
can
as
do this.
private practitioners can still get together, collect the data, and really use it that way. I think Jackie Persons does something pretty similar in Northern California with many of the people who work with her.
For sure. Absolutely. And I know there are lots of universities doing sort of that clinical collaboratives, collecting data. But thank you, David. That was really very enlightening, and I'm really excited to have heard it, and I'm excited for people watching to learn and for governments to collaborate. So, what would the first step be for them to do? Let's say if somebody wanted, after watching this video, do they reach out to you? Do they? Uh,
Well, a lot of the arguments that we use to persuade governments and to get things going are in a book that Richard Layard and I wrote called Thrive, The Power of Psychological Therapies, or in the US version, it's called Thrive, How Better Mental Health Care Saves Money and Transforms Lives.
okay.
And so they may want to have a look at that and they can see all the arguments. Um, that book has really helped in a number of different countries. So, for example, it has recently been translated into Korean
Mm,
and helped the Korean Psychological Society to persuade the government to give people a public right to psychological therapy, which they didn't have
mhm.
before. It was also translated into Dutch, and I'm told it's had a similar effect on in terms of developing a public right in Belgium. Um, so that's one source. Um, People might also like to go on our free therapist resources website. So our clinic has a, a website called OXCADAT, so OXCADAT resources, all one word, .com. And you will find there quite a lot of detailed lectures on the IAP program and materials to support people through that, but also actually lots of video illustrations of our cognitive therapy programs for anxiety disorders and therapist manuals. It's all free, and please register. You need to register, but it doesn't cost anything, and use it as you wish. It's currently used in 176 countries, and we have round about 60,000 therapists using it. So you would join a sort of worldwide movement and give us feedback. We're always trying to add things to it. But our general view is the internet is there for free dissemination of knowledge.
Thank you, David. We'll be sure to add those links and add the different translations of the book on the WCCBT website for sure. But thank you so much for joining me today. I appreciate
Well,
it.
well, thank you for having me as your guest, Lata. It's been great fun.